Welcome back, guys. Now we'll discuss about the differential diagnosis of solid masses in the liver. Whenever there is a question saying that on the imaging there is a central scar, it is the focal nodular hyperplasia. One solid question for USMLE step 2, please. The focal nodular hyperplasia is basically a congenital anomaly where it is associated with an artery. That is why you will find a central scar. The focal nodular hyperplasia is common in women who are at least 30 to 50 years, I would say. But in the question, you will find as a 43-year-old female patient. Remember, patient on oral contraceptives, that is women, usually have hepatic adenoma. But the complication of hepatic adenoma will be asked in the USMLE step 2, it is the hemorrhage or the malignant transformation that can happen in hepatic adenoma. In order to differentiate between focal nodular hyperplasia and hepatic adenoma, it is the triple phase helical CT scan that is the investigation of choice, where you will find a hyperdense lesion with a central scar that is suggestive of focal nodular hyperplasia, please. Remember, focal nodular hyperplasia is a congenital anomaly, so there is no treatment that needs to be given, but you will have to differentiate the focal nodular hyperplasia from hepatic hemangioma, please. Remember, whenever there is an enhancement that is moving from periphery to center and there is no central scar, that is when you will have to think of hepatic hemangioma, please. In hepatic hemangioma, there is no central scar, but there will be enhancement, which is basically enhancing when you are moving from periphery to center. That is the diagnosis of hepatic hemangioma. Next most common solid mass is the regenerative nodules in patient with cirrhosis, and easily you can identify patient with cirrhosis in the question. That is the patient will develop a chronic liver disease, please. Next we talk about hepatocellular carcinoma, where there is history of chronic liver disease and the patient will be having hepatitis or cirrhosis. And in the question, there will be elevated alpha fetoprotein. That is the diagnosis of hepatocellular carcinoma. Whenever there is a single metastatic lesion with the background history of cancer, it is the liver metastasis. That is the differential diagnosis of solid liver mass in patients with malignancy history, please. Liver metastasis is one most important thing. Talking about the hepatic adenoma, it is the ultrasound that is the first investigation of choice, and the contrast CT is the definitive investigation where you will find peripheral enhancement in hepatic adenoma. Remember, patient with OCPs and patient who has got androgen use will be the common presentation in USMLE step 2, please. What is the treatment of hepatic adenoma? Whenever there is a hepatic adenoma that is asymptomatic, do not do anything. Whenever there is asymptomatic hepatic adenoma, in the options, if you find stop oral and oral contraception, please do select oral stopping oral contraception as one of the most important management. If the patient is symptomatic and if the patient has got more than 5 centimeter size, it is the surgical resection we usually do for hepatic adenoma. Next, I want to talk about the metastasis to liver. Basically, the metastasis to liver is from the gut because it has a dual blood supply, that is from the large intestine and also from the pancreas. So pancreatic cancer and colorectal cancers are the two most common malignancies that we see in hepatic metastasis, please. Next, we talk about hepatopulmonary syndrome. This is because of the arteriovenous shunting in the lungs. It can usually present with patients with chronic liver disease and it takes years to develop, please. Hepatopulmonary syndrome basically presents with difficulty breathing when the patient is standing up. That is the most important clinical examination, and the platypnea is one of the most important clinical examination findings. You will have to pick it up. The patient mentions that the shortness of breath is worse when standing. The only condition in medicine, as far as for USMLE is considered, it is the hepatopulmonary syndrome whenever there is platypnea. Next, we talk about another clinical examination finding where the patient will be hypoxic in upright position or standing. That is also called as orthodeoxia, please. Next, we talk about the pancreatic abnormalities. First, we talk about acute pancreatitis. In USMLE step 2, it is the alcohol abuse that is the most common. Second most common is the gallstone and patients who are on furosemide or patients who are on ACE inhibitors. Remember, furosemide is a common cause for acute pancreatitis. Whenever you think of acute pancreatitis in the question, they will mention that the epigastric pain is radiating to the back. The patient will be having an amylase that is elevated. Very important. Lipase is most sensitive for pancreatitis. If lipase is elevated, it is a diagnosis of acute pancreatitis until otherwise proved. Remember, in acute pancreatitis, there can be elevation of ALT as well, but the prognosis or the severity of pancreatitis is usually determined if the patient has got hypotension, patient has got hypoxemia, patient has got hypocalcemia. That is what you will have to think of, please. Acute pancreatitis complications will be easily asked. Patient can develop ARDS, patient can develop sepsis, patient can be admitted to ITU. This is a clear surgical problem, please. Acute pancreatitis. Next, we talk about gallstone pancreatitis. We talked about gallstone pancreatitis when we are talking about complications of gallstones or complications of complicated cholecystitis. Gallstone pancreatitis is one of the most important presentations where you will find a liver enzyme that is elevated, that is the ALT, which is usually elevated. Whenever there is pancreatitis secondary to gallstones, it is the amylase or lipase that can also be elevated. How do you confirm it is the gallstone pancreatitis? What did we study? It is the ultrasound that is usually sensitive to pick up the gallstones. So, right upper quadrant ultrasound must be done. Whenever right upper quadrant ultrasound is normal, you can do ERCP as well, please. The treatment for gallstone pancreatitis, first thing is control the pain because patient comfort is most important, and then you will have to make sure that the IV fluids are given because patient with pancreatitis can present with the hypotension. Remember, whenever there is pancreatitis, the patient must be nil per oral or nothing by mouth. Next, we do a cholecystectomy after resolving the pancreatitis, please. Next, I talk about post ERCP pancreatitis. Patient has got dilated bile duct and is being evaluated for one of the investigations. Now the patient presents with abdominal pain that is epigastric and is radiating back. It is post ERCP pancreatitis. Patient has got fever, patient has got epigastric pain, patient has got inflammatory markers that are raised. Think of post ERCP pancreatitis, and infection is one of the most common organism because sorry, infection is the most common cause that is causing post ERCP pancreatitis if the patient has got fever in the question. I also want you to understand that ascending cholangitis is one of the most common complications that can be presenting as pancreatitis, please. Remember, post ERCP pancreatitis, the patient can come back from the procedure normally and patient will develop a gradual onset of nausea, vomiting, and epigastric pain that is radiating to the back. That is how you will have to diagnose post ERCP pancreatitis. Next, we talk about triglyceride induced pancreatitis that indicates that there is increased triglycerides. Usually, the patient is pregnant and is in the third trimester because trimesters in the third trimester, it is the triglycerides that is elevated. I remembered it as third trimester triglycerides are elevated. Whenever there is triglycerides that are increased, it is basically because of the increased triglyceride production, and there will also be lipophosphate lipase that is activity is decreased. When you want to diagnose triglyceride induced pancreatitis, it is the triglyceride level that is more than 100, which is usually 150 in the exam questions, and you will have to think that it is a triglyceride induced pancreatitis. Coming back to the management of triglyceride induced pancreatitis, it is, and for pancreatitis it is the epigastric pain radiating to the back is the most common diagnosis, most common clinical symptom. So you can easily think of pancreatitis when you think of the symptom epigastric pain radiating to back. So all the pancreatitis will have the same symptom as well. But management of for pancreatitis or triglyceride induced pancreatitis, it is the IV fluids and the pain control that needs to be done first. Okay, the question in the examiner in the question will mention that the IV fluids has been started. What is the next most important thing? You'll have to check glucose, because for triglycerides to decrease, we will usually consider insulin infusion. Whenever there is glucose of more than 500, it is the insulin infusion that we need to give. And whenever there is glucose that is less than 500, we will have to consider plasma exchange as one of the most important complications, most important treatments. But remember, when the patient has got hypocalcemia, or when the patient has got uh, lactic acidosis, or whenever the patient has got a raised lactate on VBG, what do? You will have to consider plasma exchange as well. Please remember, glucose less than 500 or patient has got complicated pancreatitis, it is the therapeutic plasma exchange. In the options, they will give you, interestingly, apheresis. Please select plasma apheresis. That is the plasma exchange that we will need to do. Next, we talk about chronic pancreatitis. It is basically because of the recurrent acute attacks of pancreatitis that causes chronic pancreatitis. Patients with alcohol abuse will be more predisposed to chronic pancreatitis. Remember, whenever there is chronic pancreatitis, the function of pancreatitis is lost. Whenever there is the function of pancreatitis that is lost, patients usually presents with steatoria, patient usually presents with malabsorption. Very important. And in the question, you can also find that the patient has got cystic fibrosis or the patient has got malignancy. Think of chronic pancreatitis, please. How do you diagnose chronic pancreatitis? It is basically the CT scan. But for some reasons, examiners are giving mostly the CT scan shows calcifications. What is your diagnosis? It is the chronic pancreatitis when the CT scan shows chronic, when the CT scan shows calcifications, please. Next, I also want you to understand that the treatment for chronic pancreatitis, it is the pain, and pain management. And then whenever you want the chronic pancreatitis to be managed, it is the prevention of recurrent acute attacks of pancreatitis that we usually do. Remember, whenever there is chronic pancreatitis, all the enzyme or pancreatic enzymes are lost. So, pancreatic enzyme supplements are usually given. It is the creon that we usually give with every meal. Please, very important. Next, we talk about pancreatic pseudocyst. When we talk about pancreatic pseudocyst, it is basically because of the formation of a capsule. Whenever there is a formation of capsule after an acute attack of pancreatitis, think of pancreatic pseudocyst. Whenever the cyst is formed and there is a thick capsule around it, it is basically the enzyme rich fluid that is being accumulated. Whenever there is enzyme rich fluid that is being accumulated, it is basically the increased serum amylase that we usually see, because pancreatic pseudocyst is associated with pancreatitis. Whenever the fluid is tested, usually not tested, but whenever there is a leak of pseudocyst, it is basically causing the increase in the serum amylase as well. Remember, the treatment of pancreatic pseudocyst is important because there are a lot of complications associated with pancreatic pseudocyst. I'll tell you, it is the pleural effusion and pancreatic ascites that is one of the most common things the patient can present with. These are the two most important complications. Whenever there is a pseudocyst that is near the vessel, it can cause aneurysm because it can compress the vessel and it can cause dilation. That is how the patient presents with pseudo aneurysm. Whenever the patient presents with fever in cases of pancreatic pseudocyst, it is the infection that you will have to think of, and it is an infection of infected pseudocyst that we are talking about. Recurrent attacks of pancreatitis. Now patient has got infection and on the CT scan there is a thick fibrous capsule. Think of infected pseudocyst, please. Very important. So the treatment usually lies if the patient has got complications or not. If the patient has not got any complications, it is the symptomatic management that we will have to do. If the patient has got symptoms and complications, it is the endoscopic drainage of the pseudocyst that we will have to do, please. Endoscopic drainage is the ultimate treatment for patients with the complications of pseudocyst. Very important. Next, we talk about pancreatic cyst can be congenital, can be normal. But remember the complications, the characteristics of pancreatic cyst are very important. It is the large size of the pancreatic cyst that we need to think of. Whenever the patient has got solid components in the pancreatic cyst, think of malignancy. Whenever the patient has got an irregular wall, think of pancreatic cyst that is at risk of malignancy. Whenever the patient has got a dilated duct associated with pancreatic cyst, think of malignancy, please. Very important, easy to remember and easy to recognize. Large cyst more than 3 centimeter with irregular capsule, with solid mass, with duct dilation, think of malignancy. That is why you will have to do an endoscopic ultrasound guided biopsy for patients with the pancreatic cyst. High risk features, please. Very important. Whenever you find pancreatic cyst and there are no complications or no high risk features, it is the asymptomatic treatment or symptomatic approach you will have to follow for pancreatic cyst. But whenever there are complications, it is the surgical resection that we need to consider. Next, we talk about pancreatic ascites. One of the causes for pancreatic ascites is pancreatic pseudocyst. So, whenever the patient has got pancreatic ascites, please look for the rupture of pancreatic pseudocyst, or it can be because of the damage of the pancreatic duct. Whenever there is pancreatic ascites, the patient will develop abdominal distension. That is the common clinical symptom which the patient complains of. And this pancreatic ascites gradually builds up, so patient can also develop weight gain. The diagnosis is usually by identifying the free fluid, that is by ultrasound. However, the definitive diagnosis is by CT scan, where you can also identify the pancreatic pseudocyst, please. Whenever you think of pancreatic ascites, the confirmatory step is basically with diagnostic paracentesis. Whenever there is pancreatic ascites, it is the amylase that is increased in the ascitic fluid, and the serum albumin ascites gradient is decreased because total protein is also increased in patients with the pancreatic ascites. Next, we talk about pancreatic cancer. Recurrent attacks of acute pancreatitis leads to chronic pancreatitis. Whenever there is chronic pancreatitis, it is the pancreatic cancer that the patient develops. Whenever there is pancreatic cancer, remember the family history is also important, which is usually not asked, but in the questions they can mention that there is a first degree relative that is usually affected with pancreatic cancer. The common clinical scenario associated with pancreatic cancer for USMLE step 2 is Peutz-Jeghers syndrome, where the examiner mentions that the patient has got mucosal lesions or mucosal pigmentations around the mouth. That is when you will have to think of pancreatic cancer, please. Next, we talk about the risk factors for pancreatic cancer. It is the cigarette smoking that is most commonly associated with pancreatic cancer. Other than that, I don't want you to remember anything. Whenever the presentation of pancreatic cancer in the question, the examiner mentions you that a 54-year-old male patient who has got a history of chronic smoking, now presenting with the epigastric pain that is radiating back, that is worse usually at night and is worse with eating. Think of pancreatic cancer. Obviously, whenever it is a cancer, weight loss is the most important symptom that we will have to think of. Remember, if the patient has not got an epigastric pain but has got a pain which is worsening on eating, and patient that has got pain that is worse on lying and with weight loss, but without epigastric pain, I want you to think of pancreatic tail cancer, because pancreatic tail cancer usually does not present with epigastric pain, but it presents with the back pain, please. Very important. The most common thing associated or mentioned in the question is superficial thrombophlebitis, that is associated with pancreatic cancer, also called as Trachea syndrome. First, most important investigation that you will have to do is a CT scan of the abdomen, please. But if CT scan is not diagnostic, then you will have to do a ERCP, please. What is the first most important advice that you give for patients with pancreatic cancer? It is the smoking cessation that you will have to do, please. Whenever there is pancreatic cancer, I want you to remember that the metastasis of pancreatic cancer is also important. Patient presenting with hepatomegaly with epigastric pain, think that the patient has got a metastasis to liver, and now the patient presents with hepatomegaly, cirrhosis, and ascites. This is how you will have to think of. Whenever the examiner mentions that the patient has got a migratory superficial thrombophlebitis, you will have to think of pancreatic cancer, please. The serum marker associated with pancreatic cancer is CA 99, also called as cancer associated antigen 99, please. Next, we talk about malignant obstruction, malignant biliary obstruction. Remember, whenever there is malignant biliary obstruction, it is the cholangiocarcinoma. Whenever I remember cholangiocarcinoma, it is a 54-year-old female patient presenting with pigmentation, dark stools, dark urine, and with weight loss, that is cholangiocarcinoma, and pruritus as well. The serum markers will be elevated, that is the carcinogenic embryonic antigen that is elevated, and the initial investigation on is abdominal imaging, either with an ultrasound or a CT scan. But remember, in the question, it is a CT scan that is usually given, because CT scan can also give you the extent of the disease. Next, I want to talk about Trachea syndrome. Trachea syndrome is nothing but a superficial vein thrombosis that is unexplained and is characteristic of pancreatic cancer. Remember, the most common cancer associated with Trachea syndrome is pancreatic cancer. The next most common cancer is lung cancer, please. Next, I want to talk about causes of steatorrhea. Whenever there is pancreatic insufficiency, there will be steatorrhea. Whenever there is bile salt related disease, or whenever there is inflammation of the bowel, or whenever there is something growing in the bowel, or whenever there is bile salts problem, it is associated with steatorrhea. The most common things you will have to remember for USMLE step 2 is Crohn's disease and bacterial overgrowth. We all know that a female patient presenting with pruritus and is asymptomatic, it is the primary biliary cirrhosis. Male patient presenting with ulcerative colitis, it is the primary sclerosing cholangitis. They are also associated with bile salt causes of steatorrhea, please. Remember, if the patient has got Crohn's disease and has got a surgical resection of the ileum, it can also cause a steatorrhea. What did we study in gastroenterology in medicine? It is basically a patient presenting with iron deficiency anemia. In young patient, it is the celiac disease. Iron deficiency anemia, patient presenting with elderly patient presenting with iron deficiency anemia, it is the cecal cancer that we will have to rule out. Remember, celiac disease can also be a presentation of malabsorption that can impair the intestinal absorptive surface, that can also cause steatorrhea. Patient with a recent history of travel, now presenting with diarrhea and with weight loss, think of giardiasis as one of the most important causes of steatorrhea. Patient who has got HIV and now is presenting with problems of gastrointestinal tract, think that the patient has got acquired immunodeficiency syndrome, which can also cause impaired intestinal surface area. And the most important problem we think is the AIDS related enteropathy, that is also a cause of steatorrhea, please. Next, we talk about some of the causes where Whipple's disease can be present, but it will also involve neurons and it will also involve cardiac. That is how you will have to diagnose steatorrhea secondary to Whipple's disease. Next, I talk about the interesting syndrome. It is called as small intestinal bacterial overgrowth syndrome. Whenever there is bacterial overgrowth, it usually presents with malabsorption and there can be bloating. Apart from these two, there can be mild abdominal pain as well. Why do small intestinal bacteria grow whenever there is anatomical abnormality? Usually because of the strictures or whenever there is a surgical blind loop. Sometimes patients with scleroderma who has got motility disorders will also develop small intestinal bacterial overgrowth syndrome. Whenever the mucosa in the gut is not right, that is, whenever there is atrophic gastritis or whenever there is absorptive capacity of the gut that is decreased and whenever there is chronic pancreatitis, small intestinal bacterial overgrowth syndrome usually happens. Remember, whenever there is small intestinal bacterial overgrowth happens, there will be malabsorption. So the patients usually presents with macrocytic anemia. B12 and folate absorption is impaired. Whenever B12 and folate absorption is impaired, it is the hypersegmented neutrophils on a background of stricture, on a background of chronic pancreatitis, on a background of scleroderma, on a background of post-operative or blind loop. That is when you will have to think of small intestinal bacterial overgrowth. In order to make sure that the patient has not got any vitamin B12 and vitamin A, D, E, K abnormalities, you will have to correct the vitamin deficiencies as well. Remember, the small intestinal bacterial overgrowth syndrome, there will be a lot of bacteria. So the management usually lies in the treatment of bacteria, that is with rifaximin, please. Whenever I think of small intestinal bacterial overgrowth syndrome, it is the differential diagnosis I am worried about. What is the patient examiner asking exactly? Is it associated with any surgery and the patient has got hypotension and patient has got diarrhea? It is a dumping syndrome whenever the patient has got a history of gastric bypass with sympathetic activation causing hypertension and diarrhea. It is the dumping syndrome. That is, dumping syndrome is associated with malabsorption of vitamin B12 and fat soluble vitamins such as A, D, E, K. That is when I will think of small intestinal bacterial overgrowth syndrome in a background history of macrocytic anemia with background of strictures, scleroderma, surgical blind loop, atrophic gastritis, and chronic pancreatitis. But when I think of dumping syndrome, it is the diarrhea after having meals and patient has got gastric bypass surgery, please. Whenever I talk about small intestinal bacterial overgrowth syndrome, I want you to understand that the bacteria growing in the gut are basically streptococci, E. coli, bacteroids, and lactobacillus. The diagnosis for small intestinal bacterial overgrowth is basically you'll have to diagnose or you'll have to prove that there is bacteria. So you will do a jejunal aspirate and also you will do a culture. Whenever the culture shows more than 10 power 5 organisms per liter or per ml, it is the diagnosis for small intestinal bacterial overgrowth. Remember, carbohydrate breath testing can also be asked, but jejunal aspirate and culture is the most definitive diagnosis for small intestinal overgrowth syndrome, please. When we talk about dumping syndrome, we understood that it is basically because of the stimulation of the sympathetic system. So patient will present with hypertension, tachycardia, increased bowel movements. I want you to understand that the treatment for dumping syndrome is basically frequent small meals and advise the patient to eat slowly, please. If the management has not been achieved with the lifestyle modifications, I want you to try octreotide. If octreotide fails, it is the reconstructive surgery we usually consider. But the most important management asked in USMLE step 2 is frequent small meals that we will have to take. Next, I talk about small bowel obstruction. Whenever there is small bowel obstruction, patient presents with vomiting, patient presents with nausea, patient presents with abdominal pain, patient presents with the colicky abdominal pain as well. The most important initial investigation I do is an X-ray because abdominal X-ray in upright position usually shows air fluid levels. That is how I diagnose the patient with the small bowel obstruction. Remember, on auscultation, there will be hyperactive bowel sounds that are usually seen. There can also be dilated bowels whenever the abdominal obstruction is severe. The complications for small bowel obstruction is important because the patient can have any strangulation, the patient can develop perforation, the patient can develop necrosis of the bowel as well. So make sure you treat this patient as an emergency patient. Remember, when the CT scan is given, please do select the CT scan as an appropriate investigation as well. Whenever there is perforation, the pain will be changing and there will be guarding, there will be peritoneal signs as well, please. Next, I want to talk about the small bowel obstruction versus ileus. What did I say in small bowel obstruction? The vowel sounds are increased. Hyperdynamic bowel sounds are present. Whereas in ileus, on abdominal examination, it is the reduced bowel sounds or absent bowel sounds I want you to understand. And ileus is most commonly because of hypokalemia, most commonly because of opioids. Whenever there is ileus, you will have to treat the reversible conditions, please. Whenever there is small bowel obstruction, there is associated large bowel obstruction as well. Remember that. Whenever there is small bowel obstruction, there is no large bowel obstruction. But in ileus, it is the small bowel dilation and the large bowel dilation that is usually present. And this is how you will have to differentiate between small bowel obstruction versus ileus. Thank you very much. I'll see you in the next session.